Welcome everyone. My name is Kareli. I'm director of Gestación Subrogada México. I am very happy to be here today. And today we will talk about an important medical topic in surrogacy with our guest, Dr. José Luis Rivas Aguilar, a reproductive biologist with a great experience. So he will explain the medical process in a clear and simple way. So thank you, Doctor, for being here with us and explain how the process works from your side. Okay, the medical part. So let's start to the first point. Can you explain us about the medical test for surrogate?
Fantastic. Thank you so much, Curly, for the space. This is the surrogacy programs they always have an intense list of questions, especially and of course regarding the selection of a surrogate and the process of how is defined whether a surrogate is a good candidate or not. And this starts uh, all the way in it, it starts on the clinic history and the medical profile of a surrogate. But I want to be clear into certain um, medical past history that is very relevant for us. First of all, it could be, I mean, the beginning of a selection will be on age. I mean, starting from age, I think nobody after 35 years old should be proposing themselves as a surrogate. The second point will be the body, I mean, the constitutional body. We can talk about body mass index, but anybody that is in the context of obesity should not be part of a surrogacy program. Of course, we want to minimize the medical conditions that a surrogate has. But sometimes we have surrogates that maybe have some thyroid problems, maybe have some um, insulin resistant problems. And I will say those can be participants, but we need to be sure that they are under control. Um, the next part should be the obstetric history, which is important that a surrogate, if she wants to be a surrogate now, um, at least has had a pregnancy before. Sometimes we have requests from surrogates. I want to be a surrogate, but I've never been pregnant. That's not the ideal prospect of a surrogate. So if you see, I'm starting as age, body complexity, medical history, uh, obstetric history. And on the obstetric history, we need at least one pregnancy, but also we want to know how this pregnancy evolved. Was it a normal pregnancy? Did the pregnancy have any complications? And which complications are we talking about? Because if we're talking about premature delivery, then there is a 20% chance that the next pregnancy is going to be a premature delivery too. If you have a premature rupture of membranes, that is also a risk that can repeat itself. And and did the baby made it to full term? How was the weight of this baby? And did I mean, of course, the method of delivery is to be concerned. I would not say it will rule out a surrogate, but if it was a natural delivery or if it was a C-section. And the reasons of it, I mean, how the natural delivery went and how the C-section ended up. Um, I will say on the obstetric history, one thing that will rule out a surrogate will be, on my point of view, if you have more than 4 C-sections. If you have a preterm delivery before 36 weeks, and if on your pregnancy you end up having any hypertension problems through your pregnancy, or diabetic um, problems during your pregnancy, any hard complication on a pregnancy, I will say would rule out a surrogate. Um, but once we have a 33-year-old non-obese with no relevant medical history, with maybe two vaginal deliveries full term without complications through the pregnancy, and she has obviously cleared out the psychological part, the socioeconomical part, the other investigation that as an agency you do, and she wants to be participant, then it's our turn to start running more tests, and tests that are going to be pinpointing at uh, very specific reproductive matters. And we will start with, again, a medical history on the obstetric precedents, and then we will go into imaging studies such as an ultrasound. In an ultrasound, of course, we want to see that the ovaries have no problems, cysts, or masses. And the uterus is a clear uterus in the ultrasound pictures. What are the complications of what we can be looking into an ultrasound? If the ovaries have any cysts or masses, and if in the uterus there are any tumors or fibroids imaging. After that, we will go and do a hysteroscopy, which is take a look inside the uterus to identify any potential um, lesions that occupy the environment of the uterus inside in the cavity of the endometrium. And this is very important because um, sometimes an ultrasound can miss an image inside the endometrium. Sometimes, and depending on who did the ultrasound and the quality of the image, you might not see things. But um, and in order to assess the endometrial cavity, you have two tests mainly. One is called hydrosonography, which is to squirt water inside the uterus, and then with an ultrasound, see how the cavity is. Um, and can I share my screen? Because I think I can show you some of the images that will resemble this kind of tests. But um, but hydrosono can be a way. On my preference, on my personal preference, I would much rather do. I think you can see my screen now. But I would rather much to do a hysteroscopy. This will be a hydrosono, and this is the uterus. And inside, and we squirt water into the uterus, and we can see the wall of the uterus. This is a very well-defined image, and we can say, in a way, this cavity is clear. Nevertheless, the hysteroscopy will give us a more precise image of how actually the uterus looks like, right? So in a way, if I can pick, I will always pick the hysteroscopy, because the hysteroscopy will allow me to see. Of course, in the hydrosona, we can also assume certain things, but the hysteroscopy will let me see this in more clarity. And of course, there are conditions that can be treated and would not have a impact on the future of a surrogate, such as a polyp. It would not have a huge impact. But if we are dealing with a potentially Asherman syndrome or severe adhesions, then this is something that would potentially rule out a surrogate. Um, I sometimes I have found surrogates that they never went into a hysteroscopy and they have already did two embryo transfers, failed embryo transfers. We do hysteroscopies and we found a polyp or a fibroid. So this is a very crucial test for me to go into the surrogate to establish the integrity of the endometrial cavity. Besides the rest of the tests, such as um, cultures, so we are not dealing with any chronic or acute endometritis. Of course, all the STD panels that we run to make sure that the immune response and that she has around uh, herpes, chickenpox, like these conditions that they can present into during a pregnancy. The surrogate needs to be tested for HIV, hepatitis B, hepatitis C, RPR. Um, of course, glucose, liver function, kidney function, cardiac assessment. It's always nice to for the surrogate to have a cardiac assessment to see how the function is and how she will be doing during a pregnancy. Um, on the reproductive side, the cavity is obviously our main intention. And of course, in the cavity, we can go into the new tests that are available, such as the endometrial receptivity assay, to the biopsies that will determine any autoimmune condition or any chronic or acute endometritis. Um, the imaging also can suggest any potential adenomyosis, which those will be conditions that potentially could rule out a surrogate. Um, so far into the selection of a surrogate, I think if, as I said before, we have a non plus 35-year-old with non-relevant medical history, with a good obstetric outcomes, and with a clear cavity, and the rest of the studies are in the normal parameters, I'll say that's the surrogate that we can take in and we can start working with. Um, regarding the endometrial, I mean, so far, is that clear? Do we have any questions around screening of a surrogate?
I think the question can we talk about at the final of the
Okay,
session?
okay,
If
okay.
you feel comfortable with that, of course.
Yeah, yeah. So, on as I said, also there's the psychological assessment, there's the cardiac assessment, there's the um, socioeconomical assessment. There are other assessments. I will just stick into this reproductive, which on my main is of course the medical history, and then a lot of the endometrial cavity to be assessed properly. Um, I also know that, well, so far at the screening, I think that's covered. Um, do we want to make another topic?
Yes, I would like to, can you guide us about the IVF process step by step? Once the medical screening up for surrogate, thinking everything going well, and
Hmm,
what
hmm, hmm,
happened
hmm.
in what moment?
Okay, so of course, in the surrogacy environment, we always have patients that have already went through IVF and then they have embryos in storage, which on that scenario, what we will be working on will be on the thawing of an embryo and the transfer with a previous preparation of our surrogate. In the patients that have not gone through any IVF or they have not created embryos, then what we need to establish is are we going to work in, if we're dealing with a couple that somebody's going to give the egg and then the other couple is going to give the sperm, or are we dealing with donations of any other um, biological material? But nevertheless, both scenarios will end up with having an egg and having a sperm. Um, of course, there's a lot to talk about any like selection of a donor, for example, or there's a lot to talk about the an analysis that we normally do on a semen sample and what are the conditions that we will um, like to work. Of course, we like to work with the best samples, but not is not always the case. So um, eventually, we will find out that we have a sperm sample and then an egg. The way that we achieve an egg is through the stimulation of an ovary. And then what we do is we extract the egg from the follicle of the ovary. I think I have a video of that. Let me show you that. So what we need to do is to stimulate the ovary. Then with a vaginal probe, we go under anesthesia and we poke each of the follicles. Once we poke them and we retrieve the egg or the follicle fluid, in the follicle fluid, the egg will be present most of the cases, most of the times. And once we have the egg, it goes to the IVF lab. And there's two ways to fertilize an egg, and that's what I think is important to mention. One is the IVF, or the traditional way, which is basically we have the egg and we prep a semen sample and we put a drop of the semen sample, which will contain thousands of sperms. And in a natural way, of course, in an incubator, but in a natural way, one single sperm should fertilize the egg. So that would be the traditional IVF protocol. Of course, in order for us to choose this technique, we need to have a very good semen sample, ideally, because the better the sample, the higher rate of fertilization through IVF, this technique. And the other technique will be through ICSI or ICSI or ICSI, which essentially is to have the sperm on a needle, which you see here. We're very minimal and tiny and insignificant. But we poke the egg and we deliver the egg inside. We deliver the sperm inside the egg. So when do we choose this? Of course, when the semen sample is suboptimal or has some abnormalities, and we need to pre-select our sperm. And the pre-selection happens with the prepping of the semen sample, with the isolation of the best moving sperms first, and then with a high zoom lens of a microscope, we go and select the best forms or the best morphology, the best looking sperm, let's call it like that. And once we select that best looking sperm, we isolate it, and then we pick it up and put it inside the egg. Of course, when you do that, your fertilization rates can be higher, and IVF versus ICSI fertilization rates are different. Most likely, ICSI will be higher. What do I, when I say fertilization, is because when you have an egg and you have a sperm and you combine them, or you put them inside, the first step to be analyzed is the fertilization. And I will show you in this video on a time-lapse incubator how the fertilization happens. So if you see down here, we have 4.1, and this is the hours of the number of hours that the egg that already has a sperm inside have been in the incubator. So after this, we will search for the fertilization. And the fertilization is the presence of two pronucleus. Of course, at this moment, we can talk about slow embryo growth or fast embryo growth or abnormal embryo growth, but this is called fertilization. If I don't have fertilization, I'll repeat that, I would not end up having an embryo. If an egg does not get fertilized, it would not develop an embryo. So the first step is very crucial. So that's why the first decision to be made as how we are going to fertilize an egg is important. After the fertilization is achieved, the next is the division of our embryo. And our embryos are going to divide all the way from day 0 to hour 0 to our 121 or 150 at the most, which is day 6, day 5, day 6, and sometimes we take them to day 7, according to how the development is ongoing. But after the fertilization, the embryo development is what comes next. And on the embryo development, we need to make sure that they are growing, or we can assess if they're growing or if they are not growing. And it's normal that the count starts here, and we end up with less. And when I'm talking about that is when you retrieve eggs, and let's say we retrieve 20 eggs, out of the 20 eggs, the first thing to know is how many of those can we work with? And you can only work with mature eggs. So on a donation of 20 eggs, we will expect more or less 18 or 17 mature eggs. They could be 20 mature eggs, or they can be 10 mature eggs. It depends. A lot of factors play a role there, but I will say a good number of mature eggs will be around 12 to 15 mature eggs. And the reasoning behind that is because the first time that you're going to lose on that count is when you fertilize them. So sometimes we can achieve 100% of fertilization, but that's not reality. The reality is around 70 to 65 to 70% of fertilization rate. So if you have 20 mature eggs, you will fertilize 17 or 16. And then out of these 16 fertilized eggs that have the potential to go to day 5 or day 6, not all of them will make it. More likely, 50% of those fertilized eggs will make it to day 5 or day 6. The rest are going to be arrested, are going to get blocked, are going to degenerate, and are not going to make it to day 5, day 6. So, of course, an embryo that does not make it to those days is an embryo that did not have the potential quality of a full embryo. So, with the ones that achieve the development of day 5, day 6, we have two options. And one option is we can have three options. One option is once we are in day 5, day 6, we can immediately transfer it to our surrogate, and that will be considered a fresh embryo transfer. A fresh embryo transfer is just a transfer of the embryo achieved at this moment. With the rest of the embryos, if we have more embryos, we can freeze them, which will be the other option, or we can biopsy them and then freeze them. The biopsy nowadays can be for two things. One is to know the PGTA, or to know the order of the chromosomes of our embryos. And the other one is to know the chromosomes of the embryos, but also to find a specific genetic condition that both of the donors potentially have in common. Let's just say, I don't know, maybe cystic fibrosis. Both of them they present the same gene condition. And we need to make sure that the embryos that we're going to use are not going to have this genetic condition. So we can do a biopsy and we can search for a specific gene. We cannot do a full genome still, but a specific gene, we can run it. Nowadays, more studies are being developed and can be done into an embryo, but I will stick to those two, the chromosome order of our embryos and the genetic condition, if there's some genetic condition on both donors. The biopsy normally is done before we freeze our embryos, essentially to avoid any more manipulation on the embryos. We do have cases where patients did not want to biopsy the embryos, we freeze them, and then later on they want to biopsy them, and we can thaw them and biopsy them. But this comes with a risk of any anything can go wrong or can damage our embryo. So what my suggestion is to know beforehand that we're going to biopsy these embryos in order to, before we freeze them, we take the biopsy. And once we take the biopsy, we send the biopsy for analysis, and the embryos get storage. The biopsies will leave the office and go to a lab that only do genetic testing, but the embryos, they will always be kept in our facility. So no embryo will be leaving the facility, just the biopsies. Biopsies will come back and they will let us know if we have normal or abnormal embryos. And of course, they will, if we want to know the sex of the embryo, we will know the sex of the embryo. And if you have both male or female normal embryos, you can choose, if you have a preference of a female or a male embryo, you can choose which one to be transferred. Talking about the selection of the embryo, we will start with the normality of the embryo, and then we will continue with the morphology of the embryo, because morphologies are associated with implantation rates. A more good-looking embryo will have more potential to implant. A low-grade embryo, but it could have a less potential to implant. Of course, if I would not say don't transfer that embryo that has low morphology. If it's normal, it's a normal embryo, and we should be transferring, even though it has a low morphology, because we have already stated that it's a normal embryo, and the potential of pregnancy still exists there. Once we have this is the report of a genetic test. On this, we will know which embryo we're going to be using and transferred. And once we have that, we can also make this a little bit more specific with ERA or endometrial receptivity assay studies, where we for sure will know the number of hours that the endometrium of our surrogate needs of progesterone. So we can narrow down what are we going to use. And after we achieve a pregnancy, we can do, we can search for the DNA of the baby in the surrogate and repeat a genetic test. Normally, that's not much necessary, but we can do it again to reassure what we have. So, all the extra embryos that we can have that are achieved in the cycle will be in storage. And every time that we want to transfer an embryo, we can thaw them and transfer them. I will say that is a very quick resume of the IVF process. There will be a lot more to talk about the selection of a donor if it's needed, or how the sperm is selected, or the studies to be done in the sperm, the carrier test that can be done on both donors. But essentially, I think that's it.
Of course. Thinking, doctor, for example, the embryos are already ready to
Created.
implant.
Mhm.
What about the most risk, or what about the successful rate in the first one embryo transfer?
The success rate will be defined as will be success rate is associated to different factors. As I just mentioned right now, the embryo factor plays a role. If we have low-grade embryos, then that can be diminished. If the surrogate has not been fully studied, and we don't want to run extra tests that can be affected too. But I will say if we have a good embryo with a very well studied surrogate, we should be around the 65% rate on the first embryo transfer, second embryo transfer on the 70, 75, and a third embryo transfer around the 75 to 80. Um, yeah, that would be a rough success rate. But of course, every case will have its own.
Okay, thank you so much. Now I would like to open the space for questions. Please feel free to write them here in the chat or ask directly to the doctor. Um, I have seen two questions in the chat, so I would like to read it. The first one is, if I have a question, some clinics say unlimited embryo transfer. This sounds good, but it can also scary to me. It is positive or negative for us as parents and surrogate as well.
So, if I understood good, can you repeat that again? Sorry.
Yes, some clinics says unlimited embryo transfer. Sounds good,
Okay.
but also scary to me. It is positive or negative for us as parents and surrogate as well.
Okay. So I mean, of course, the unlimited embryo transfer scenarios would always depend on how many embryos you have, right? And I don't think, for example, if you're going to go on a fourth embryo transfer, I think at that point you should be changing your surrogate. There's a whole scenario of immunity role that this specifically surrogacy cases play on, because we're not using the egg that is the same body, and when we're creating embryos that are um, unfamiliar for that endometrium, if by the second embryo transfer, or even by the third embryo transfer, we have not achieved a success pregnancy, having a full studied surrogate, having a good quality and studied embryo, then we are in a cascade of potential immunity roles that could be affecting this. So I will say you don't go into a fourth embryo transfer without previously questioned yourself if you want to change that surrogate. So even if you, I mean, eliminate embryo transfers, what I will say is, do I have unlimited candidates to be using? Because if that's the scenario, then I will not be subjecting the same surrogate for more embryo transfer rather than seeking somebody else. And that would potentially be a scenario to explore. Um, yeah, I don't know if that answered the question though.
Thank you. The second one is, what factors influence whether a transfer is successful?
What are the factors that condition a successful embryo transfer?
Mhm.
Okay, so I think as I said, study it, well screened, um, no major medical treatments on the surrogate, um, and a good quality embryo. A good quality embryo. Of course, there are a lot of add-ons to be done in an embryo transfer. Maybe I should talk about embryo transfer. Um, so I will say every clinic, every doctor will have a different way to prep an endometrium. Everybody will say they have their special thing. And I think on that, there, for me, there are three major steps. The first one is that the day that I'm starting my endometrial preparation, I'm starting with a baseline endometrium that is not thick. I don't want a thick endometrium to start prepping it. Of course, in this start, my hormonal levels, my progesterone is low or -1. My estrogen is less than 100. My ovaries are at rest. Then I start the preparation with estrogen. And after 6 or 7 days, we will reassess this endometrium. And it should be increasing in thickness. And the ovaries will continue at rest. And my estrogen on blood work is increasing, but my progesterone is not. We will decide if we need to increase the estrogen intake or we can keep it the same according to the thickness that we have that has achieved by 7 days. Then the next checkup is before we start the progesterone intake. And in this matter, I'll say you need to have at least more than 7 to 8 millimeters of thickness. Ideally, you need to have 9, 10, great. 200 picograms of estrogen or estradiol in the blood. And your progesterone needs to be less than 1. If before you start the progesterone, you're already having high levels of progesterone or levels above 3 or 4, that means that endometrium has already been under the stimulation of progesterone and it's already expressing changes in the morphology of the endometrium that are not compatible with you transferring an embryo 5 days later because it's already changing. The progesterone is the one that triggers the receptivity markers in the endometrium. So before we started, we make sure that it's negative or -1. And then we're sure that we can start it. Once we start the progesterone, the next step, 4 steps now, will be before the embryo transfer. Now I want to make sure that the estrogen level is still good enough, but now my progesterone level needs to be above 10. There are studies that correlate this concentration to a better or higher success rate. So I want to make sure that it's above 10 before the embryo transfer, 1 day before the embryo transfer. If we have progesterone less than 5 or 6, I will cancel the cycle. Sometimes we have progesterones in 9, and the next day we rerun our test and it's above 12 or 13, and we move forward. But yeah, I'll say that. And then, of course, on the day of the embryo transfer, the management of how the embryo thaw, how it recovers, how well expanded it is, how all the after thawing process. And you would expect by that time to know the way of how to navigate the uterus of that surrogate. Because I would also say that an embryo transfer that starts getting complicated at the moment that you're doing it will stress the embryo. Because if I go and I cannot go in, and I multiple tries, I cannot go in, I'll have to bring back the embryo to the lab. I'll have to start working my way into the uterus, and then they will bring it back to me, and then I end up the embryo transfer. So that's complicated embryo transfer. So you want to have a non-complicated embryo transfer. Sometimes you can see, and most of the times you can see how the drop of is delivered inside the endometrium. Sometimes you don't see it. And then corroborate with your lab that the embryo has actually left the catheter. So you corroborate that. That means that the embryo is inside, and make sure that the medication and the protocol that you have established with your surrogate continues to be delivered. And I think that that's why we do all the other previous steps. Because if somebody stops taking medication, the estrogen is going to go down. Even sometimes the endometrium you might not see it in the endometrium, but you can see it on the blood. And if somebody stops taking the progesterone, we will know that too. Or started accidentally before we said so, we will know that too. So those are safety nets also, in order to assure that we end up having an embryo transfer on the ideal conditions of it. Before we start an embryo transfer, I also want to have, or we ask that there are vaginal cultures that are negative, just to reassure that we're not dealing with any infection at them. And yeah, I think that will be it.
Okay. I don't know if someone else have a question and want to ask directly or put it here in the chat.
Yes, I have two questions.
So,
Talking about the tests that should be or could be run in the embryos, besides PGTA and ERA, are there more tests that should be run or are advisable to be run?
okay. Besides the ERA, another advisable test to be run on the endometrium. So the ERA has also two minor brothers, one called Emma and the other one called Alice.
Okay.
And those other two
Tests will evaluate the healthy bacteria that lives inside that endometrium and the non-healthy bacteria. And that's what I mentioned, the chronic or acute endometritis. Yeah, I think it will, if we're going to do a biopsy for ERA, you might just want to do the Emma and Alice too, to know the microbiomic of that endometrium. There's a lot of controversy around the ERA, and on my personal experience, I'll say I will stick to, if you have 4 embryos to transfer, you don't need to do an ERA right at the beginning. But if you don't have more than 2 or 3 and more than 3 embryos, then you might want to consider it before going into it. On my experience, whenever we have had an endometrium that was displaced of the window of implantation, and we adjust that, then we achieve the pregnancy. So on my experience, it has worked. It has also not worked. We move it, we adjust ourselves in that time frame, and it did not take either. But then again, when we're talking about surrogacy and then all these immune factors that play a role, we cannot be ignorant about those and we cannot think about those. Of course, they exist. And that's when, at that moment, it's like, okay, we did our maybe 3rd embryo transfer. I consider we should not go to a 4th embryo transfer, right? But there's no way to know the immunity condition of because we can know it, and there's some studies if the donor is the same. I mean, if it's a couple, let's just say, and they're going to receive the embryo, we can know about the immunity of that. But when we're using an egg donor or a semen donor, then everything changes. So yeah, I'll say we will have to change surrogates at that moment. Another study around the uterus, there's other one that focus a little bit more on the adenomyosis state. If there is an image ultrasound suggesting adenomyosis, my call will be, let's go and do an MRI. If the MRI confirms that there's adenomyosis, my suggestion will be, let's not work with her.
Okay, but that would be a test to the surrogate, not to
the
the embryo.
surrogate. Correct.
Okay. So overall, do you advise ERA study or these ones that you mentioned now, Emma
Yes.
and Alfred? Yes.
I will say yes, but also take it to a discussion of the case and the number of embryos that we have available.
Okay. Thank you. I think
Of course.
Can I ask another question,
Sure.
Kathleen? Okay,
Oh, well, I'm
so
not the moderation.
I
I
was
say yes.
wondering. I was wondering. I think Carol is okay with it. I was wondering if, when choosing a donor, is there anything medical that should be considered, or is that covered up front? Kind of lost with this, so that's why I'm asking.
Yeah, I think it should be another talk about talking donation, because on that, I don't know, I just have a call right now with a patient and we are between two donors, and there's so much to discuss. But I will
Okay.
say, carrier test. We should have carrier test on both. The one that is going to give us the semen sample and the donor. And then, yeah, going through how many eggs, how many mature, the conversion of blastocysts that she had, the normal of normal embryos. Yeah, I think that is something to have a full talk about it. But yeah, multiple tests on that.
Okay, but
Tests before stimulating the donor. Oh, yeah. Before. No, before. Everything is before. Before you create your embryos. Because once you have your embryos, there's so much that you can do on them. You want to know before that if you want to analyze a specific gene, for example. Yeah, that's a PGTA, right? The PGTA, it's regardless the presence of a gene condition. The PGTA will analyze the chromosomes of the embryo, not the genes. The PGTM will be looking into the potential, the presence of an abnormal gene. Okay.
And for that, you both need to know if before you create the embryo, there is abnormal genes that match each other. But that's why would you do it before?
That would be another test. The PGTM, was that it?
PGTM. But that's only done if your donor has this genetic condition and you have this genetic condition, both the same. And then if both of the same have the same gene condition and it's an egg donor, my first will be choose another one.
Okay.
But if you really like her and you're like, no, I really want that. Okay. Then we need to, once we create the embryos, I need to ask and tell the lab, I need to find this abnormal gene in the embryos that we create.
Okay.
Because there's a 25% chance that the condition will be expressed in the embryo that has the abnormality. And if we're talking about cystic fibrosis, that's not a condition that you want to have on your
to have
kid.
in the child.
Yeah. So I will say. I see a question here. It says, do you use IM or intravaginal progesterone? Any change with using glue or other methods to couple things? Okay, so this is a good question. So both vaginally, intramuscular, and also there's a new progesterone that is subcutaneous, which resembles and creates the same concentrations as the IM, which is way much more tolerable and manageable for the surrogates. It's less painful, and the concentrations are great. So I will stick to subcutaneously and intravaginal. Embryo glue, good question. I rather use HCG wash, and that's something that I do on embryo transfers. I also do endometrial PRP. The embryo glue, I think, is not so significant. I'll go into endometrial PRP. I'll go into HCG wash. That's some things that we will implement that.
Okay. Well, thank you all. I don't know if someone else want to raise something, but if not, you can ask the question directly and we're going to share with the doctor. Thank you. Thank you, doctor, for your time. To all of them for joining in this webinar. This information I hope was clear and useful. So our team is always here to guide you in this journey to parenthood. So have a wonderful day, everyone.
Thank you.
Thank
Thank
you.
you so much.
Bye bye.
Bye-bye.